For our next speaker is Dr. Nada Hindia, who's a clinical assistant professor of neurology at Stanford and clinical director of the research at the Headache Center. We actually refer a lot of patients from the concussion clinic to the Headache Center because they have prolonged migraines, and we found them to be very helpful.
Thank you very much. So thank you for that introduction, and thank you all for being here this afternoon. And I think Dr. Steenerson's talk is a great segue into mine. So I'm really going to talk about headache management following head injury. So as we've seen, headache is actually the most common acute symptom following TBI. The majority of TBI is actually considered mild TBI, with about 75% being considered mild, with patients reporting up to 90% following a mild TBI experiencing headache. So generally speaking, the prognosis for these patients is pretty good. So the prognosis for acute, or what we'd call post-traumatic headache, is generally favorable, with most patients experiencing headache remission within about 6 months. But some do go on to develop what we would consider persistent post-traumatic headache, or persistent PTH. And these patients are often the ones that we see in our headache clinic and oftentimes become the most challenging or the most difficult to treat. And studies suggest that up to 78% of patients with mild TBI will have some forms of headache up to 3 months after injury. Up to 58% of those suffering a TBI will have significant headache 1 year after trauma. And about 20% will continue to have headache about 4 years after trauma. So there's no real definitive way to identify who's going to develop persistent PTH. However, there's evidence to suggest that women, those who have a history of primary headache disorders, such as a history of migraine, those who have a lower socioeconomic status, those who have a mild severity of head trauma, and those who had short duration of post-traumatic amnesia tend to be at a higher risk. And although we can't really modify these factors, there are some risk factors we can modify, which specifically would be things like medication overuse and psychiatric symptoms. So medication overuse is very commonly actually one of the features that transforms episodic migraine into chronic migraine. And this is commonly seen as a transition into chronic or persistent PTH as well. So we really want to stress with our patients to really limit the number of acute or abortive medications they take in a month to less than 10, because that in studies has seemed to limit or lessen the severity of what we'd call medication overuse or rebound headache. And although no causal relationship has been proven for psychiatric symptoms such as depression or anxiety or personality changes, we do know that they're increased in patients with PTH, and they may contribute to the development of chronic PTH, and also in increased headache-related disability. So really, it's important for all of our patients to get psychological and psychiatric evaluation when needed. So before we discuss treatment options, let's take a look at how the International Classification of Headache Disorders, the 3rd edition, defines post-traumatic headache. So PTH is coded as headache attributed to trauma or injury to the head and or neck. And it's defined as acute when it lasts less than 3 months, and is defined as persistent when lasting longer than 3 months. And then it's classified as either moderate to severe injury or as mild injury. So since the majority of TBI is considered mild, we'll take a look at the ICHD-3 diagnosis of mild TBI. So certainly there has to be some sort of trauma to the head. And headache onset generally has to be within 7 days of injury, but this isn't a definitive rule, because oftentimes we will see patients who develop headaches weeks or even months after an injury. And so there are some clinical features that they cannot have, which are listed here. So there should not be any loss of consciousness for greater than 30 minutes, a GCS of less than 13, amnesia or altered awareness for more than 24 hours, or any imaging evidence of trauma. if any of these factors are noted or any of these features on exam, likely that wasn't a mild TBI, it was more a severe TBI. And there are some clinical features that are required. So there is a requirement for at least one of these features, a transient confusion or memory loss, or two or more of the symptoms such as nausea, vomiting, visual changes, dizziness, or gait abnormalities. So we do have established criteria for diagnosing PTH, but when it comes to treatment options for PTH, that becomes a little bit more controversial. It's a little bit less clear. So there was a very recent retrospective study that looked at patients receiving either the most commonly prescribed preventives after mild TBI, which were gabapentin or tricyclic antidepressants such as amitriptyline, versus no oral treatments. And they looked at headache severity, or what they noted here to be the headache score, over the course of the next year. So what we see on the figure on the left is that headache scores decreased over the year regardless of medication group. So whether you were receiving gabapentin, a TCA, or no medication at all, headaches did improve. And the second graph shows us a little bit more detail what happens when we give certain medications. So what we have to note here is the patients that were prescribed medications or preventives typically had more severe headache. So what we see with gabapentin is in their first follow-up after being prescribed gabapentin, there was a significant decrease in their headache score. So they improved pretty rapidly. This wasn't sustained. It didn't continue to improve over time, though. And with the TCAs, what we see is there wasn't that immediate change right after they were prescribed a TCA, but over the course of their next visits, there was significant improvement. So what does it make us think? So we know that headache is going to improve over time, but it's not going to improve with the same frequency for everyone. And so for someone in my clinic who comes in who's not particularly very disabled, maybe has a headache every so often, I may not necessarily prescribe a preventive. But for somebody who's disabled from their headaches, who can't do the things they normally do, I would want to treat with a preventive, and I would want to treat very early. So what do we use to treat? Well, post-traumatic headache actually lacks any evidence-based treatment guidelines. So most treatment recommendations are really based on expert opinion. So it's really based on the phenotype of the headache that it most resembles. And it was previously thought that tension-type headache was the most common type of post-traumatic headache, but more recent evidence, and clearly what we see in clinic, is that migraine is the predominant form of PTH. And so today what I'll focus on is prevention of those types of headache or migraine headache. And let's talk a little bit about what migraine means or what the definition is. So migraine is a headache that lasts anywhere from 4 to 72 hours, and it has to have two of these four features. So it has to be either unilateral, moderate to severe in intensity, throbbing or aggravated by routine physical activity, and it has to include either nausea or light and sound sensitivity. So if somebody comes in with a moderate to severe headache that gets worse when they do some routine physical activity and they have some nausea with that, they will meet the criteria for migraine. Whereas tension-type headache, by definition, lacks any of these characteristics, and it's mild by definition. So really, a tension-type headache would not bring a patient into a clinic. So if a headache is severe enough to warrant evaluation, it's most likely going to be migraine. So that being said, PTH can really look like many types of headache disorders. Most commonly we see migraine, but oftentimes we see a combination of these. So typically I'll see someone who comes in the clinic who certainly meets the diagnostic criteria for chronic migraine, but also has components of occipital neuralgia with tenderness, but is also using Advil, let's say, 15 days out of the month, and maybe a triptan 10 days out of the month. So they'll also meet diagnostic criteria for medication overuse headache. And really what happens with chronic migraine or any chronic type of headache is it can be quite disabling and really requires a multidisciplinary approach to treatment. So along with acute and preventive treatment options in oral medications, we also use many interventional treatment options, such as Botox for chronic migraine and trigger point and occipital nerve blocks. And we also combine that with many behavioral therapies. So I'll touch on all of these next. So let's take a look at some of the acute treatments that we most commonly use. So as you might know, triptans really are the mainstay of treatment for acute migraine, and we have many options out there. So all of these options listed do come in oral formulations, oral tablets, but for people who have significant nausea and vomiting, both sumatriptan and zolmitriptan come in a nasal spray. Rizatriptan and zolmitriptan come in an oral disintegrating tablet, and sumatriptan also comes in an injectable form. So this can work really well for people who have rapid onset headache and who would want a decrease in headache as soon as possible. So the first 5 triptans listed here have a half-life typically of about 2 to 4 hours, but some patients have a slower onset of headache with a much longer duration. So for those types of patients, I really look at triptans such as naratriptan and frovatriptan. Naratriptan has a half-life of 8 hours, and frovatriptan has a half-life of 26 hours. And then if triptans either don't work for patients or they're not finding enough benefit, dihydroergotamine or DHE nasal spray is certainly an option to try as well. NSAIDs certainly can be used, but most of the time patients that are coming into our clinic have tried NSAIDs and they haven't been helpful, but they remain options to those who haven't tried them. And antiemetics can also be helpful either on their own or as adjunct therapy for nausea, vomiting, and we oftentimes use them for a severe migraine. So they can work as a super rescue, and really we use them often to try to help patients not have to go to urgent care or go to an ER, because oftentimes if they do go to an ER, they'll get a combination of IV infusions, including one of these antiemetics. So we're going to try to do that at home before they need to go in. And some just important pearls to know about acute treatment options. We really want to use a full dose of an acute medication, especially with the triptans. So take, for instance, sumatriptan. It comes in 25, 50, and 100 milligram tablets. I will always only prescribe that 100 milligram tablet. It's very unlikely that 25 or 50 milligrams are going to work in our patients, especially in our adult patients. And triptans really work the best the earlier they're given in a headache. So they work best right at the beginning. So I tell patients, the second you feel that headache coming on, take it. You're allowed to also repeat the dose of a triptan. So you have to wait at least 2 hours, and then you can repeat that dose. So then what I tell patients is if that's still not helping, that's when you think about adding your adjunct antiemetic, so something like promethazine, to really help you try to avoid going into the ER. A couple really important things to note is opioids and butalbital-containing substances such as Fioricet should never be used for the management of headache, and we never use those in our clinic. And one other really important thing that I touched on earlier is really limiting the use of all acute medications to no more than 10 days in a month. And I really encourage all of my patients to keep a headache diary so they can log not only, on that day their headache intensity or any other features they may have had, but also any abortive medication they took. That way, when they come back for follow-up, we can not only see if their headache severity and frequency has reduced, but we can also make sure they're not running into rebound or medication overuse headache. So oftentimes, abortive treatments for migraine prevention aren't enough. And a lot of times, that's when people start overusing their medications. So if we notice patients are overusing medications, or they're having several headache days a month, or they're significantly disabled by their headaches, that's when we really have to think about preventive treatment options for headache. And a practical treatment goal here is to really aim for a 50% reduction in either headache frequency or severity. And we have to be realistic with our patients. This isn't going to happen overnight. This is going to take several months, so I encourage them to not stop their medications and let me know if there's any side effects, because we can always modify that. There are no randomized clinical trials in PTH, but there is evidence to support efficacy for several treatments, including amitriptyline, topiramate, propranolol, and valproate. And these can be used alone or in combination. I might start at a very low dose and increase slowly. And always want to consider comorbidities when you're picking any sort of preventive treatment option. So a lot of our patients will have insomnia along with their headache or chronic migraine, so I oftentimes will choose a TCA, and I most commonly choose nortriptyline just because of its better side effect profile in comparison to amitriptyline. So these are just some of the medications out there that we can use for migraine prevention. When we actually look at what's FDA approved for episodic migraine, there are only 4 medications. It's propranolol, timolol, valproate, and topiramate. I've never used timolol on anybody, and I've never prescribed valproate either. So most of the things we're using are actually off-label, and it's okay, and we'll use that most commonly. Chronic migraine, actually, there are no FDA-approved oral treatment options, and until the approval of the anti-CGRP antibodies this last year, onabotulinum toxin, or Botox for chronic migraine, was the only FDA-approved treatment option for chronic migraine. Oftentimes what happens is patients will require a combination, oral medications plus injectable treatments. And with oral medications, I'll have them come back in follow-up. If, like, for instance, we've started nortriptyline, we've started at 10 milligrams, we've increased weekly up to 50 milligrams, but they're having some side effects. I'll either take them down and then add on another therapy like Topamax or maybe Botox. If they say they've had no benefit, we can stop it completely, but if they've had some, it is worth keeping them on that medication and then adding on some others. So let's also take a look at some interventional treatment options. There is some evidence to support Botox injections for post-traumatic headache. The most extensive study to date was a retrospective one that looked at 64 male veterans aged 20 to 50 who had a chronic PTH diagnosis. A majority of them reported a continuous headache, and they were injected using the Preempt protocol and the follow the pain paradigm. So the Preempt protocol is the typical protocol we use for Botox for chronic migraine. It's 155 units. And with the follow the pain paradigm, you can increase up to 195 units in certain areas. And on average, these patients got anywhere from 3 to 4 cycles of Botox. And the majority reported some improvement. So what we see down here are the Preempt protocol injection sites. So it's 7 different muscle groups, 31 injection sites in the frontalis, the procerus, the corrugators, the temporalis, the occipitalis, the cervical paraspinals, and the trapezius. There's only a few spots, though, where you can increase the dose in the follow the pain protocol, and that's the trapezius, the occipitalis, and the temporalis. So oftentimes what I'll do in addition to this is peripheral nerve blocks. And they've widely been used in treating post-traumatic headache. And the most common sites shown here are the greater occipital nerve and the lesser occipital nerve, which are branches of the cervical roots, and the supratrochlear nerve and the supraorbital nerve, which are branches of the trigeminal nerve. So local anesthetic to these nerves is thought to result in an afferent feedback to the trigeminal nucleus caudalis, part of the trigeminal vascular system, helping shut down or slow down that headache generator. And oftentimes I will combine nerve blocks with trigger point injections. And we have like a couple minutes. So, well, first, what we use for nerve blocks and trigger point injections as well. Typically, we'll use an anesthetic. In our clinic, we usually use bupivacaine 0.75%, but lidocaine is also widely used. Steroid is actually never recommended in any type of headache other than cluster headache. So we'll never add steroid, and we'll inject volumes anywhere of 0.5 to 3 milliliters per site. And in terms of frequency, this varies very widely. So I go based on a study that was done in 2015 looking at chronic refractory chronic migraine. And what they did was actually inject patients weekly for a month and then monthly thereafter, and found a significant reduction in chronic migraine. So that's typically the pattern I start with for patients. And I'll typically add in my trigger points to that, and these are some of the most common sites. Usually I'll do lots of sites around the neck and around the trapezius, and really I'll go based on where the patient's pain is. And a couple last things, like one of the most important treatments we're going to add to our therapies is behavioral. And there is a lot of evidence to suggest these can be helpful in migraine prevention: relaxation training, biofeedback, and CBT. In PTH, overall the results have been mixed, but there is promising evidence to suggest that when you combine these modalities together, they can be very helpful. And the earlier you start them, the better the outcomes for patients. And lastly, the foundation of headache and migraine management is regularity. So I always recommend patients to sleep regularly, to keep a wake-up time and a sleep time the same every single day, to eat meals on a regular schedule, and to do aerobic exercise every day on a schedule. And I think that's all. Thank you for your time.